Thank Migraine Association of Ireland and Pascal for letting me do this, as well everyone coming here to join this talk. Really delighted, and it's a pleasure to be here. So the chat we're going to go over today is the role of physiotherapy in headaches and migraines. For most people, headaches and migraines, the first thing you think of is not going to a physiotherapist. So the big thing we're trying to cover today is one thing. All I want is at least one thing you guys learn today, and I think it'll be a success. All right, let's get started. So first, we're going to chat about the MDT approach, so the multidisciplinary team. So as you can see with this puzzle here, so these are the main puzzle pieces to who migraine patients are going to be dealing with: the GP, the physiotherapist, the consultant, headache nurse, Migraine Ireland, and psychologist. Physiotherapy is one of the many important pieces to the puzzle, but not the only piece. So where do we usually fall? Where do we start with patients? So commonly, we'll be one of the first points of contact with patients. So they might have seen the GP, might have seen the consultant. They've been given pharmacological interventions. They're taking Excedrin, different types of medications. They come in to see us. They're dealing with a bit of neck tension, neck pain, but they also mention, I have migraines, I have headaches, I struggle with this frequently, a couple of times a week, a couple of times a month, whatever the frequency is. So it's very important as this working together as a team. As a physiotherapist, we're going to let the patient know of Migraine Association of Ireland, let them know of the other pieces of the puzzle. And once we send them to Migraine Ireland, you guys are amazing, very, very good at liaising with the rest of the team. And that makes our job so much easier. So that's just one part of it. Another part is a patient comes in, they've seen the GP, consultant, headache nurse, psychologist. They've seen loads of different consultants, healthcare practitioners, and then they go to Migraine Ireland, and then they're referred on to us after taking all the different types of medication, potentially already had Botox treatment, and they're just hoping something else will help. And that's where they come to us, and hopefully we're there to be able to relieve some of the symptoms. So we're going to talk about three types: headaches and migraines. So the tension type headaches, cervicogenic headaches, and migraine with neck involvement. So it's important to note, physio can only treat headaches that involve the neck. So this is going to involve the joint, the muscle, and the disc. And 70% of migraine sufferers have neck pain. So vast majority of patients with migraines will have neck pain. However, not all of them will have a neck involvement that's contributing to the headache. So that's a very, very important part, is not every single patient is going to have a neck involvement or presenting with neck pain, but the ones that do have the neck involvement, those are the ones we can treat. And that's the vast majority of the migraine patients. So determine if you have a neck involvement, come into a physio, we assess, determining if there's a neck involvement, and then we go over the points of treatment to try and relieve those symptoms. So as you look at this chart over here, it's important to note cervicogenic headaches, tension type headaches, and migraines, they can coexist. Most commonly, you're going to see the two tension type headache and migraine together. You could have all three, but it's most important to note it's not just one at a time, just the migraine. You could have more than one. So if we start off with the most common tension type headaches, so these are seen as bilaterally, patients having on both sides. So if we're thinking of the upper traps, I'll be saying this word a lot, the upper traps, these muscles, the upper trapezius, if you're having tension here, these could cause headaches coming up to both sides of the head. Then we go to cervicogenic type headaches. These would be less common than tension type. They would have a strong muscle involvement as well, so the upper traps, but they also involve the joint. So we're thinking of the joints in the neck. You have two joints on either side, the facet joints. So if we're thinking of one side, this could cause a headache to one side, so more unilateral for these type of headaches. And as we know, migraines, a neurological disorder, which I'm sure you've heard this explained hundreds of times about migraines. We're going to go over bits and pieces of things. Migraines are similar to cervicogenic and tension type, and it's the commonality. It's 3 times more common in women. And the thing to note is the strong muscle and joint involvement. It's not always the case with migraines. It doesn't always present with the neck involvement. So patients don't always come in saying, I have neck pain. That's where the physios come in to assess if there is some sort of neck involvement. So we're going to go over the link between headaches and the neck involvement. So if we look over here at this chart here, a lot going on. So we look at the trigeminal nerve. That is the fifth cranial nerve. It provides sensory innervation to the face. So these are the pathways it takes to go up to the brain. Then we look at this long band here. This is the TCN, the trigeminal cervical nucleus. Long word, just think of TCN for this one. So it has a common convergence with the spinal nerves. So we're looking at C1, C2, C3. So this is in the neck. So this is the first vertebrae, second vertebrae, third, and these sensory innervations are going to the TCN as well. So they share a common pathway to the TCN. So because of that common pathway, it allows cervical pathology, so neck issues, to refer this common pathway up towards the head. So if we go over to this one, this is a bit of an easier chart to look at. So imagine we have neck tension, so muscle tension in the upper traps. This could cause pathways sent to the TCN, which then causes headache. And this is just a vicious cycle that continues to go if we don't take that neck tension away. So as physios, our job is to try and take that neck tension away so we don't keep switching on the TCN, which then causes the headache. So for the physiotherapy assessment, it's our job to identify the neck involvement. So we're going to start off with muscle, a very common one. As I said, very common for the tension type headaches. So going back to the upper traps, we could have muscle knots, or also known as myofascial trigger points, causing the headaches. So we're going to look at if there is any inflexibility or trigger points in there that's causing the headaches. What are some of the triggers? A common one here you'll see in a lot of these is poor posture. So I sit for some parts of the day where I'm doing admin. A lot of people have desk-based job where they're sitting for long periods of time. Everyone does it. I do it myself. You sometimes put around the spine, neck goes forward, chin down, and you start feeling a little bit of tension here over time. It's very common. As well, you could have an injury, hormonal issues, dehydration, and stress. Next, looking at joint dysfunction. So think of joint stiffness or instability. As I said, this could be more one-sided, causing the unilateral, the cervicogenic type headaches. We're looking at the triggers for this one. Poor posture, again, myofascial dysfunction. So the muscle tension, if the muscle is very tight, it could cause that joint to be stiff. Then we're thinking of disc dysfunction, which we'll cover next, and injury. So we're looking for any kind of joint irritation or stiffness that could be causing this. Going next to disc dysfunction. So this could give rise to this joint and muscle dysfunction. So if we're thinking of a disc dysfunction, a lot of misconceptions would be a slipped disc. No, we're thinking more of a disc protrusion. So if you think of a disc, think of like a jam or a jelly donut. So with the jam donut, the inside of it is a fluid-like, a jelly-like structure. The disc in our spine, the inside, the nucleus, is like a jelly-like structure, okay? So it's the one that's allowing compression. So it's going to be allowing all the forces going through the spine. So if there's a big injury or there's something that gives rise to this dysfunction, this jelly-like fluid is going to seep out, most likely backwards. So it's going to protrude backwards, this jam-like fluid, and this could give rise to the muscle and joint and other symptoms. So what are the triggers? Injury would be a big one, wear and tear with age, again, going back to the poor posture, neck leaning forward, causing that protrusion backwards, diseases such as OA and RA. Very, very important to know your triggers. So going back to the Migraine Association Ireland, I'll be talking a lot about them today. They're very, very good. They give out free headache diaries. So when we're one of the first points of contact and they don't know about the Migraine Association of Ireland, we let them know to get in touch with them. And once they're in touch with them, they're able to get that free headache diary. And that allows them to know their triggers. Because as a physio, we want to give them as least amount of triggers that are going to trigger the headache, as well as the least amount of frequency that the headache occurs. So these triggers can be get in the way sometimes. And one of the more common ones are going to be stress and sleep. So we're going to go over the treatment, going back to the the last two slides, the muscle, joint, and disc, starting off with the muscle. So we're going to touch on this a little bit later, dry needling trigger point. So that's one thing that could help release the tension within the muscle, as well as breathing techniques. So the upper traps, one area that gets very tight or when we're stressed, this is one of our secondary muscles for breathing. So there's breathing techniques to help relieve that tension. Then we go into joint, just joint specific, we're looking at mobilization. So with joints, if there's stiffness or irritability or irritation with the joint, there's mobilizations as physios we can do to help increase the joint movement or reduce that joint stiffness. Then for muscle, joint, and disc, what works for all of them? As I said before, the dry needling, manual therapy, deep tissue massage, posture. It's one thing we're going to be talking a lot for those desk-based jobs, trying to get us into a better posture. This also ties in with ergonomics. So a good setup at home, a good setup in the office. Then lastly, exercise rehab. So you're thinking of what are the areas in the body that are very tight that we need to release, and what are the areas that might be underutilized, that are a bit weak, that we need to strengthen to get us in a better position. Then going into the disc lastly. So as I was saying, the disc protrusion. So as it most likely is going to be protruding backwards towards the, a potential nerve, pinching a nerve, or just potentially giving rise to the muscle and the joint dysfunction. This could cause certain symptoms. So there's a method called McKenzie method, which is helping reverse those symptoms. And it's helping get that jelly-like, that jam-like fluid, the nucleus, back into the disc to relieve that tension. So the next few slides, we're going to talk about trigger points and myofascial trigger points and dry needling. So we're going to start off with this first picture over here to the left. As you can see, this needle, and this is the needle we use for dry needling. So very, very thin needle. More times than not, you don't even feel it going in. It's the same exact needle as acupuncture. And this is the upper trapezius muscle, the anterior fibers, so the front of the muscle. Then we go over to the chart to the neck, to the right of it. These X's here are the trigger points. So X marks the spot. So that's where we're looking as a physiotherapist to release that tension for trigger point dry needling. We're looking to get the needle within those trigger points. Because as you see here, all these red dots going around the head, that's the referral pattern. So these trigger points cause this referral pattern up the head, causing headaches. So trigger point, what is it? So it's an irritable spot, a palpable spot, a taut band within the muscle, giving rise to these headaches. What is dry needling? Something very common that we do every single day with a lot of patients. Specifically for migraines, is very, very beneficial. It increases blood flow. It also reduces the muscle tension. One of the biggest ones that reduces the muscle tension, helps relieve the tension in the muscle that's causing the headache. In terms of increasing the blood flow, it also accelerates the healing response. So it creates an inflammatory response, helping repair any damaged tissue. So the upper trapezius, what we just chatted about the last slide, is just one of the many muscles referring up to the head. The first one we chatted about was the anterior fibers referring to the side of the head. Next one here is the posterior fibers. So these ones are referring to the back of the head. Then we go over to the next muscle here, the splenius capitis. This one's going to be referring to the top of the head. The suboccipital muscles right at the base of the skull, they're going to be referring just around the ear, behind and in front of. The last one here, the sternocleidomastoid, or known as the SCM. So these ones are going to be referring back of the head as well as around the eye. So these might be common areas as patients with migraines might be referring and pointing to where their headaches or migraines are occurring. And these are only a few. There are 20 muscles. There are loads of muscles in and around the neck that can refer up to the head. So now we're going to go over a little video. If you've never heard of dry needling, you've never had it done, you want to see what dry needling looks like, we're going to go over a little video here to see what it looks like. So bear with me here because the link wasn't working earlier. So I just popped this up here just in case. Everyone can see that, Deirdre? All good? Perfect. Okay. So I'm going to play it first. I'm going to do it a couple times. I'm going to play it first just so everyone could see. Then I'm going to chat through what we're seeing. Okay, I'm going to pause it there. So here's the needle. If you can see my mouse, here's the needle here. Okay. And as I was showing you guys previously, the upper trapezius, the muscle we've been chatting about a lot, these fibers are going to run from here all the way up to here. So the needle's here. So we're not just looking at the needle. We're looking at where the fibers run. So the fibers are running this way. So where that circle is, we're looking along that direction. That's where the twitch is going to happen, the twitch response. So the twitch response is when the needle hits that trigger point, the muscle is going to twitch. It's a response of the needle hitting that muscle, and then it relaxes. So that's the reaction that you're going to get from the needle hitting that trigger point. So we're going to watch it again, and just kind of watch where the mouse is and where those twitches are going to happen. So just watch along here. There's one, another one. There we go. A few small ones. And it's kind of calming down from there. Okay. Set it back to here. So as you saw, the first couple twitches were quite big, and then they kind of calm down. You could get bigger ones sometimes as well. So it just goes to show when that twitch response happens, it's quite big and it's calming down. So what it means is it's relaxing. That muscle that is very tight, that trigger point is relaxing. And that's the goal. That's what we're trying to achieve, reducing that muscle tension. But sometimes when people come in, they've heard of dry needling before, they've never heard of it. There's the word needling in it. So they're like, oh, I don't want to do it, needling. Oh, so there's loads of questions people come in to ask. So some of the frequently asked questions are, of course, is it sore? So I always ask, have you had deep tissue massage? Have you seen a sports massage therapist? They're like, yeah. It's like quite sore. And they're like, yeah. It's like, it's not that sore. It's less sore than going to see a sports massage therapist where they're really digging their elbow into you. It's easier than that. And it's going to be quicker. Where that needle was, he goes in once or twice and you're done. It takes less than a minute. Very, very quick. Is it similar to acupuncture? So the similarities I was chatting about before. So it's the same needle, very, very thin. You barely feel it going in most times. But the difference with the acupuncture is you go over the meridians of the body. So with the meridians of the body, you have these things called acupressure points. So there's one point called LI4, which relates to the nail bed of the thumb. And that point there helps with relieving headaches. Where, as in dry needling, it's specific to that area. So if we're trying to relieve tension in the muscle, we're going to stick it where the tension in the muscle is. Will I be able to exercise after? So it depends. Some patients could have soreness for 24 to 48 hours after, and that's completely normal. It's like you just did a very hard workout in the gym, the muscle's a little bit sore, you worked it quite hard. Okay, there can be some tenderness and soreness after, but the exercise will be given from your physiotherapist on what to do to help ease that bit of tension from the dry needling. And how long until you feel the effect? Again, this is another thing that depends, but a lot of patients right away, they'll get off the bed. Oh, my head feels lighter. That's great. I can move my neck a little bit better. Sometimes you'll have that tenderness for the 24 to 48 hours. And then from there, it's like, oh, I haven't had a migraine in a month, 2 months. So it does differ, but you will see the effects, whether it's immediately or shortly after. So myself as an evidence-based practitioner, I like to not only use the studies, but what I'm seeing daily. So I'm going to go over some studies for dry needling and deep tissue that shows a benefit for migraines and headaches. So these two studies and the studies after are going to be systematic reviews or meta-analysis, which if we're thinking of the pyramid of studies, it's going to be at the top. It's going to rank the highest for the hierarchy of research. So first one here, effectiveness of dry needling for headache. This is the systematic review. So 8 randomized control trials of dry needling versus sham acupuncture, manual therapy, and Botox. So 2 of them were cervicogenic headaches, 2 were tension type headaches, 1 were migraine headaches, and 3 were mixed. So they're combined between a few of them. So as I said, with that chart at the beginning, where you could have migraine as well as tension type. So all studies, every single one, 8 studies reported improvements in pain. So this was a moderate quality of evidence. So in terms of the quality of evidence, moderate quality for a systematic review is very, very good. Next one here, we're looking at the effectiveness of trigger point manual treatment on the frequency, intensity, and duration of attacks in primary headaches. So this one's looking at, without the use of needles, working through trigger points with your hands, so deep tissue and soft tissue release. There are 7 randomized controlled trials of manual treatment versus minimal treatment. So the minimal treatment most commonly was whatever the patients were taking. So if they were taking Excedrin, whatever pharmacological interventions, they were just sticking with that treatment. So that was the minimal treatment. 5 tension type headaches and 2 migraine headaches. So between these two, the tension type and the migraine, both had a decrease in frequency and intensity of the migraines. 1 trial had a decrease in duration. The only reason this is low evidence was because there was no negative effects. But in terms of the significance of the results, all were very positive. So this goes to show the dry needling as well as the manual treatment are very effective in reducing pain, as well as reducing the frequency and intensity of the attacks. So as a physiotherapist, we liaise with some of the other practitioners within our clinic that are massage therapists that work specifically hands-on massage therapy, and together working through those helps reduce the tension. As well as myself, I use a combination of dry needling and manual therapy because with the evidence, they are very beneficial. So the thing is, with patients coming in, with anyone, whether they have migraine or not, I always ask what activities they're doing outside of work. We're always big proponents about exercise. Some people come in, they're like, oh, physios make me do exercise activity. It's always something we're big to push on. And it's important to note that with migraine cases, there is a connection of low levels of physical exercise, and high frequency of migraine has been reported in many large population-based studies. So this goes to show there is a correlation between patients with higher frequency of migraines and low physical exercise, which makes sense. Patients coming in with migraines, the last thing they want to do is go out for a run. They want to go to the gym. The last thing they want to do, and that's completely fair. Why do you think that is? Because the symptoms can be very debilitating. The light can affect them, sound, so many things can affect them, whether it's in gym or outside. So how, as physiotherapists, can we change this to reduce that frequency so they're able to exercise? Because there might be other comorbidities or other issues going on that we're looking to help with as well. So we're looking at the role of exercise. So these are both systematic reviews very recently, 2019 and 2022. So the first one, the study indicates that in patients with migraine, aerobic exercise decreases the number of migraine days. So aerobic exercise seems to be beneficial for patients with migraines, reducing the amount of days of frequency of the migraines. Then we're looking at strength training. This demonstrated the highest efficacy in reducing migraine burden, also known as the migraine days or the frequency, followed by high intensity aerobic exercise. So going back second to the aerobic exercise. So what does that mean? So patients come in first, they have X amount of frequency of migraine days. For example, 5, 6 within the month. So they might, in between those days, try and get some exercise in, but with 1 day of migraine, it might take a couple days out of going to exercise. So as a physio, we have to determine, okay, what might be causing it? Do they have neck tension? We treat that neck tension with some dry needling, hands-on treatment, reducing that tension, helping reduce those migraine days. So it's giving them a buffer of reducing the amount of days or months of having migraines, allowing them to exercise, whether it's their favorite exercise is aerobic exercise, running, or it's in the gym, finding something that works for them between the two. That then continues to help with reducing the migraine days. But if there's such a high frequency that continues, the last thing they want to do is exercise. So it's the combination of reducing those symptoms, reducing the frequency, then allowing them to exercise, which is going to be good not only for the migraines, but good for other comorbidities if they exist. So little recap and future. So dry needling and manual therapy are effective treatments for migraine and headaches with neck involvement. So going back to the 70% of patients with migraines present with a neck involvement, neck pain. And that another percentage also present with no neck pain, but there is some sort of neck involvement. So that's where myself and other physiotherapists come in to assess to see if there's a neck involvement to try and treat the tension in the neck that's causing the migraines to reduce those symptoms. Linking in with the MDT for the best results. So as I said before, and I'll say it again, Migraine Association of Ireland has been great liaising together and working with patients with migraines. It's very tough, very debilitating. If you don't know, if you're yourself personally doesn't suffer with migraines, you know someone, a loved one or a friend, and it could be very, very challenging. So by coming together and liaising to make sure they get the best results, because it is very tough. So working together with Migraine Association of Ireland has been very easy for ourselves at Archview, but it's also very beneficial for these patients to give them the best opportunities possible. So a couple of things for the future. So talking about the pharmacological interventions in the beginning, like Excedrin or whatever tablets patients are taking. Some patients don't like taking tablets, and that's fair. They might be on more than one type of tablet. Something was just approved there by the FDA is the Zavzpret. It's the first nasal spray. So it's a nasal spray fast acting that helps reduce the migraine pain. So this is just another alternative for a pharmacological intervention. Next here is Nerivio. So it's a neuromodulator. So if I've ever heard of neuromodulator, it helps stimulate the nerves to reduce the tension. Most of them would be around the head. So this would be suborbital or suboccipital, and they also could be around the head, which can then cause one of the side effects, unfortunately, is headaches. As I said before, the tension type headaches, migraines, they can come together, they can coexist. So it can be a beneficial treatment, but there also is a percentage of patients that have migraines from it. Nerivio is wrapped around the arm. So this one is another one that stimulates the nerves to help reduce the migraine symptoms. Again, with anything, it can have side effects, and one of the side effects for that is arm pain, but it's not going to be risking for headaches. All right, guys, that's it for me. I really, really appreciate you guys joining the call. And as I said at the beginning, I hope there's at least one thing you guys took away from this chat. Thank you.